My name is Lisa Orloff, and on behalf of my co-moderator, Kepal Patel, and especially the American Association of Endocrine Surgeons and the American Head and Neck Society, we are delighted to welcome you to the first of what we hope will be many collaborative efforts between our two societies, serving the greater community that is interested in endocrine surgery, head and neck surgery, and especially all things related to the thyroid this evening. We are fortunate to have a panel of distinguished experts in ablative techniques for thyroid lesions. And true to the fact that we are all surgeons, we have, most of us, just come from the operating room, or actually some of our panelists are either about to be called to the operating room or are still in the operating room. So you may have some panelists floating in and out of the webinar this evening, but we all are hoping that we can provide some tips and pearls and insights into our experiences with some challenges in thyroid ablation. So again, I'd like to acknowledge our partner societies that have made this webinar possible, and our leadership, including Saray Parangi and Michael Singer, who are here joining us this evening and have helped to facilitate the process. So without further ado, I'd like to introduce our speakers. I am joined by Kepal Patel from New York University, a professor of endocrine surgery and head and neck surgery. And our panelists are Julia Noel, head and neck surgeon at Stanford University, and Vicky Banuchi, head and neck surgeon at MD Anderson, as well as Claire Graves, who's an endocrine surgeon at UC Davis. And Wrenn is currently trying to get out of the operating room at Rush University. So he will hopefully be here before the end of the hour. And the objectives of our webinar are listed here, but we hope to impart improvement in identifying patients with nodular thyroid disease that may be appropriate for non-surgical or ablative intervention, to articulate the advantages and disadvantages of ablation compared to surgery for different thyroid diseases, and to employ more refined techniques when performing thyroid ablation procedures. And you will note that we have designated the topic ablation. We aren't limiting the conversation to one type of ablation. We know there are thermal ablative techniques, there are chemical ablative techniques, and there are some evolving newer modalities that are not yet widely available. But I think what you will mostly be hearing about this evening is radiofrequency ablation, since that is the most widely available and practiced technique. But we're happy to discuss other ablative techniques as well. So as just a very brief background on the strongest indications for thyroid radiofrequency ablation, this is currently most often applied and most appropriate for treatment of symptomatic benign thyroid nodules that are causing compressive or cosmetic symptoms, or autonomously functioning thyroid nodules. And I'm sorry, I didn't delete my institutional logo there, but the ideal candidate for a radiofrequency or other ablative procedure is a patient not only with these symptomatic concerns, but one that has a definitive confidence in a benign diagnosis. And for non-functioning thyroid nodules, this typically means two benign cytologic samples and a size that's at least 2 centimeters in one dimension or more. The location of the nodule that's being targeted should be accessible, and I think that this will particularly lend itself to the topic that we're going to be discussing in some of the cases tonight, because we certainly encourage novices in ablative techniques to target easily accessible nodules, but as we get growing demand for treatment with ablation and non-surgical intervention, sometimes nodules are not quite as accessible as we would like. The composition of nodules should ideally be not only sonographically benign, but typically solid or microcystic, not so much macrocystic unless you are applying chemical ablation, but combined approaches can be used for mixed nodules. And I think all of us thought that what would draw people to ablation initially was sort of the fact that it's scarless, and it is less downtime than surgical treatment of thyroid nodules. But I think that more and more, what really draws the majority of patients to ablation is the idea of keeping their thyroid gland, only treating the nodular component and minimizing the risk of needing lifelong thyroid hormone supplementation. And furthermore, ablation does keep other options open. So for those of you in the audience who have not already started performing radiofrequency ablation, this is just an example of one of the ideal candidates that's an easily visible and accessible, well-defined benign thyroid nodule undergoing radiofrequency ablation. And you can see the acoustic changes that occur with the ablative process. But now let's move on to some cases that are maybe not quite so easy. And I'm going to just kick it off with a fairly straightforward case, but this is a 41-year-old woman who's had a long-standing history of a right thyroid nodule. It was first detected on an incidental ultrasound. She thought that she palpated a neck mass. It wasn't actually palpable, but there was a small sub-centimeter nodule in her right thyroid lobe. But over time, this nodule progressively enlarged to the point that it became palpable and had a benign biopsy in 2024. In 2025, the patient developed symptoms that were thought to be attributable to the thyroid nodule, including palpitations, insomnia, and anxiety. However, her thyroid function was totally normal, mid-normal TSH, no elevation of T3 or T4, and she had a thyroid uptake and scan that were also normal, showing actually normal overall iodine uptake, but relatively cold, decreased uptake in her dominant nodule. Her ultrasound was described as TI-RADS 4, and the nodule measured 3.5 centimeters in greatest diameter, and a second FNA was benign. Nevertheless, the surgeon that she was seeing recommended a total thyroidectomy for unclear reasons, but the patient decided to seek a second opinion, which led to a referral for considering radiofrequency ablation. So I'm just going to show the pretreatment images here, and I'd like to ask the panelists if they could just kindly describe their impression of this nodule seen in transverse section on the left side of the screen and sagittal views on the right side of the screen. Maybe I can't see the panelists at the moment because I'm sharing my screen, but maybe Dr. Banuchi, can you just start off since we'll go alphabetical?
Yeah, absolutely. Thank you so much, Lisa. Pleasure to be here with all of you. So we see here, the transverse section of this thyroid gland. We see a hypoechoic nodule that's well defined. It is deep in the thyroid gland. It abuts the posterior capsule of the thyroid gland. This is a nodule that we would definitely recommend a needle biopsy for evaluation based on size and its characteristics. And so, yeah, I would start there.
Okay. Dr. Graves, do you have any other comments to add to just the ultrasound interpretation?
I think one thing that I thought looking at it is that the kind of overall shape of the thyroid would, especially when looking at that transverse view, is nice and oblong. It doesn't look like it's, deforming the anterior capsule. It looks soft. It looks like it's compressible with a probe. So that's one thing that jumped out to me from those pictures.
Oh, that's great. Along those lines, do any of the panelists perform ultrasound elastography in their practice? There have been papers reporting that less elastic or stiffer nodules respond less well to RFA or other thermal ablation. But I personally don't perform elastography. Does anybody have experience with that? I think it's
but I'm interested to try.
Yeah.
I
kind of
have
an
the capability to do it, and I do it, and I've started recording it, but I'm not sure how it correlates. But it is I'm sure it does, and it is a very interesting thing that I think we should start doing. It takes very minimal effort to do it, just to find a representable area and measure right before and after. And I think I have started doing it. I think we're going to see some, especially as we try different technologies, I think we're going to get some useful information from elastography.
That's great. I think it hasn't gained traction maybe because it hasn't prevented the need for fine needle aspiration biopsy when ruling out malignancy. But now that we are contemplating ablation of lesions and who's going to respond or which kind of nodules are going to respond and how can we assess the nodules and their response to different therapies. Vicky, I think your comment is sage that this probably will add useful information. So, and Sean, I see you've made it. Welcome. Dr. Wrenn is here as well.
Yes, hello. Sorry for
That's
the
great.
delay.
No problem. So we're just talking about a patient with a benign thyroid nodule that's grown over many years. She wants to undergo ablation rather than surgery. And Claire mentioned the nodule has or Vicky, I think you mentioned that the nodule has a prominent interface with the posterior capsule. So I think that from the technique standpoint of performing ablation with a thermal device, what are your concerns about the location of this nodule? Let's
Yeah,
have Sean pipe in. Yeah.
okay. Yeah, I was just thinking that this, in many ways, this nodule is an ideal size for a potential ablation. Being large enough that it's a clinically significant nodule, but not too large, and that it should still have a really great response with a single session of RFA. I do think that, based on the growth over time, if it's only had one benign biopsy, I agree I would get a second biopsy prior to proceeding. And while it does have a very nice, I agree with Dr. Graves in terms of its ovoid shape, it does project a little bit in terms of on the medial aspect into that TE groove. And there could be some tough spots that in that danger triangle that might not be easily treatable.
So thanks, Sean. That's maybe I'll ask Dr. Noel to kind of uh, kind of add to that because of that concern about the tracheoesophageal groove and the posterior capsule. Would you and then any of the other panelists recommend performing posterior hydrodissection prior to ablating this nodule, or what are your thoughts on in general on posterior hydrodissection?
Yeah, it is a technique that has been, I think, now relatively well described. And the theory behind the technique is being able to separate the posterior capsule from a potential recurrent laryngeal nerve. I think in reality, we as surgeons all know that the relationship between the posterior capsule and the nerve is variable depending on the patient and whatever physiologic process is happening in the thyroid gland. And Dr. Russell and co are about to publish a paper on this, which I think will be very salient, but there's really no guarantee or way to confirm radiographically that you have actually achieved that separation with posterior hydrodissection. And so for this particular patient, while you certainly could take that approach, I don't think that you can treat the nodule with the assumption that you have separated those two structures. The other thing to touch on is just that this is a right-sided nodule. So the kind of the contact point along the posterior capsule is going to be a little bit less predictable and also less medial than it would be on the left side.
Thanks for those insights, and to the audience, take note of these points because we have more questions about this technique and nodules more often than we would like do approach this danger triangle or danger zone or posterior capsule. So you'll see more of this coming up, but this is this particular patient's examination following treatment. The nodule, you might have noted, was not particularly vascular pre-treatment, but it is less so now post-treatment. And when I performed this procedure, I did not perform posterior hydrodissection, but rather I just counseled the patient that she might have a slightly less robust response because I was going to be conservative at the deep aspect of the nodule. And that was my approach to avoiding risk and avoiding complications. So pretty common scenario. And now I'll just move on to a second case here. This is a 68-year-old woman.
Lisa, just can I interrupt?
Yeah.
We do have a couple of questions from the
Oh,
audience.
excellent.
Do we want to save all the questions till the end, or we can?
Well, let's answer some as we go if they pertain to the cases. That would be great. Yeah, if somebody
excellent,
can,
definitely.
yeah.
But then also, I just want to take this time out real quickly, just to once again, I mean, this is an amazing collaborative effort between the two societies, and I really want to, to say that this is hopefully one of many more of these webinars and sessions, and really thank the leadership of both societies, Dr. Parangi, Dr. Bevenue, for really, making this happen and spearheading this. This is really, really exciting. Quick question, and then Julie, I want you to just answer one thing I just also have. So when you do these posterior dissections or do these posterior nodules, what are your thoughts on ever having to go back into the operating room for these patients? Let's say you did not get a good response and now you have to take this nodule out for some reason. Do you worry more about those posterior nodules that have been ablated?
I do a little bit, and thankfully thus far I haven't had a personal experience with having to take a patient back on whom I've performed posterior hydrodissection specifically, but I have had a couple of patients on whom I've performed anterior and lateral hydrodissection, and they can have variable degrees of scarring, stickiness, just sort of difficult tissue planes. And I always think to myself, I'm so glad I didn't perform posterior hydrodissection in this patient, because where it really counted, it was more like a normal case. And so just based on that experience and talking to some of you about your own, I'm now, I think, more hesitant to do that.
No, I can just say from my experience of N of 1, having done posterior dissection, having to take this patient back, it's not fun. It's not a good situation. So, quick question. I'm sorry, go ahead.
Is that one of your cases coming up? I wasn't sure if I don't want to
no,
steal
no,
your thunder on that.
No, I'm not presenting that one today.
Okay.
Okay. I'm going to combine two questions into one right now. So question basically revolves around how necessary is it to do two biopsies, to have two benign biopsies before proceeding to ablation, especially if the nodule is not that suspicious sonographically. And similarly, if we're willing to do needle ablations on T1 papillary cancers, why are we worried about indeterminate nodules? Well, we can answer that second question later, but with the first question, any of the panelists, how important do you think is it to get two negative biopsies?
Yeah, I think clinical correlation is important and sonographic evaluation is very important. And patients that have nodule, if somebody has a nodule that's spongiform, which is not this case, right? And it's a TR1 or TR2, and you're very confident that there's no very low suspicion on ultrasound. I think one biopsy, one fine needle aspiration biopsy is enough. So that's how I do it on protocol. Anything above a TIRADS 2 classification with any suspicious features, I think it's very important to repeat the biopsy. And even when they're indeterminate, I mean, we can talk about that a little bit later, but two biopsies with a full extent of cytologic or molecular testing is appropriate.
I'll tend to agree with that. And I do think that, for many of us that do RFA, a second FNA that you're doing personally is a really important trial run to do with the patient prior to the RFA. It gives you a chance to talk them through all the steps. Most of us do our FNA biopsies in the exact same manner that we're doing the RFA. It allows you to ensure that they tolerate FNA biopsies well and that you got a really good sample. But if it is something that is TIRADS 2 or something that you probably wouldn't biopsy anyway in the first place, I think one biopsy is definitely sufficient.
That's great. And for autonomously functioning thyroid nodules, does anybody feel an obligation to biopsy these? Sometimes they come with a biopsy, but if you have a hot uptake on a thyroid scan, do you feel it's necessary to perform FNA before ablating hot nodules?
I still do. I ask for them to have one, or I perform one FNA prior. I know the risk is exceptionally small, and there are some international guidelines that don't enforce that, but I think we've all probably seen that patient that had the hot nodule that was never biopsied and then turned into something bad. And those nodules can have very abnormal or suspicious even ultrasound appearances. So it's nice to have the confirmation before you commit.
I agree. I do as well. I like for that. I don't do more than one, but I like for them to have a one benign biopsy for functioning nodules.
So, and especially I think in prior decades, it was there was concern that if you did a biopsy of a functioning thyroid nodule, you would end up getting a follicular lesion of undetermined significance. And now we don't use that terminology, but we also have molecular testing that can identify the TSH receptor mutation. And so it's not as likely that you're going to send that patient down the path of being concerned that it's malignant if it's not.
Right.
Great. Can you all still see my screen? I wasn't sure
Yeah.
if I flipped it off. Okay, great. Well, we can keep taking questions intermittently, but this next case is a 68-year-old woman with a multinodular goiter. She's euthyroid, and on ultrasound, she had at least 4 nodules in her right lobe. They were very benign appearing, mixed cystic and solid, benign appearing nodules in her left lobe, but a dominant nodule in her low thyroid isthmus that was progressively enlarging. And her most recent ultrasound had the following description. The isthmus was expanding into the medial aspect of both thyroid lobes with a predominantly solid, isoechoic, wider than tall nodule that flattened the trachea somewhat and displaced it posteriorly. The nodule extended inferior to the innominate vessels beyond view on ultrasound, and more so to the left of midline, measuring at least 4.2 centimeters in greatest diameter. With moderate diffuse vascularity on Doppler. So would any of the panelists do anything further if this has had several benign biopsies and the patient is very eager to have ablation? Would any of you do anything else further before undertaking such a procedure?
Come pop in. I think doing your own ultrasound is very important in this case. I don't like the extending beyond view line there. And so I would want to make sure that I can see the complete nodule with my ultrasound. And if I can't, if I have any question, I would get a CT scan to take a look and see how far that's extending into the chest.
That's great.
Agreed.
Yeah. Along those lines, do you do your own ultrasound on any patient that you would consider for ablation before, even if a nodule is very visible and well described?
Absolutely. Yeah, I think
Yeah.
it's so important to do your own ultrasound. Surprises pop up all the time with the target nodule or other nodules that show up looking suspicious. So yeah, I think it's very, very important to do your own ultrasound before doing this procedure.
Great. Well, to that end, this patient had this ultrasound appearance. And as you can appreciate, the carotid arteries are sort of converging low in the neck toward the mediastinum here. And this low isthmus nodule is displacing the trachea posteriorly and flattening it somewhat. It's a difficult view, even with one's own attempts to visualize it optimally. And so this is the CT scan appearance. Not so huge, but as you can see from the cut on the left is a little bit higher up. The cut on the right shows a little bit more lung volume, and the nodule does extend a little bit more to the patient's left and really starts to extend somewhat. It was difficult to get a good CT cut that showed all the anatomy I wanted to show. So here is the sagittal view. The nodule isn't really technically substernal, but it is starting to go retrosternal, and the innominate vessels certainly are in contact with the nodule. So would the panelists feel that this is a reasonable nodule to attempt to perform an ablative procedure rather than a surgery? Let's start with Vicky, since you're over on my left.
Yeah, I mean, I would have a good conversation with the patient about what the goals of care are and about what the hesitation to surgery is. First of all, what are the symptoms? What do we want to um, accomplish? And I always go back to even if the patient's coming for ablation, like let's go back to like what is it that you would like to obtain from that you would like to improve on, and discuss all the possible modalities. Because I think sometimes patients need to understand that even though surgery may not be what they want, it may be more efficient in terms of addressing their symptoms. So they need to understand that in this case, I would probably, if the patient is symptomatic and wants to do something about it, I would probably favor surgery. Ablation, I think, is something that could be attempted. Again, you do your own ultrasound and you see what you can see and what you can safely ablate. I don't have a lot of confidence that you could ablate most of this, but you could ablate the visible areas, and the patient may want that, even if you tell them that surgery is more effective. And in that case, it could be done, but the patient needs to understand that you may not achieve the desired result, that you may need multiple ablation sessions. And even with that, it may be unsuccessful and you may end up wanting to do surgery anyway. So what I do in these cases is I kind of explain to them that I would probably favor a surgical approach here if I don't think I can fully ablate this to in a way that it's going to be symptomatically improve the patient.
Yeah. Yeah. Claire, how often can you talk a patient out of not wanting surgery? I mean, I think these are really patients come wanting ablation. And if you say no, I don't think that means that they'll say yes to surgery. But what's your experience with that?
I think it depends on the patient, and your reasoning. I think if you're upfront and honest and say, the other thing that I was going to throw in about that location is that isthmus location can be really more uncomfortable for patients. It's harder, I think our angles are harder to get down, especially when it's going substernal there. Yeah, it's, I find it harder to try to hydrodissect with lidocaine off of that anterior trachea. They just seem to have more discomfort. And so I've had, the patients that have just really not tolerated it have pretty much all been those isthmus nodules. So that's another thing that has, I was thinking, looking at that ultrasound and CT scan. But I'd say it's not terribly uncommon for me to talk someone out of ablation. And I think I just tell them it's a really different way of thinking about things. And I think once we talk about the higher risk of the kind of having it done and not having long-term surveillance is usually what pushes people. In my experience, it's people that just say, look, I've been following this for a long time. It's getting uncomfortable. I want to be done with it. I want to, have it out.
Yeah.
But you're right. I mean, a lot of people come with very preset ideas. And so there are some that are, I think some, if you kind of give the pros and cons, we'll decide.
We lost your voice, Claire. You might just died on us.
Okay, well, we'll let you fix that, Claire. And Sean, what do you think about the idea that you can ablate the more accessible or superior part of a nodule that might otherwise be extending into the mediastinum, which will contract and then sort of elevate the part that's initially not accessible?
Yes, I forgot who coined the term, but they called it the iceberg technique, where essentially the suprasternal portion is first ablated, and theoretically, in most cases, the substernal portion would then contract and become suprasternal after an adequate treatment. I certainly don't think there's anything wrong with ablating suprasternal portions of substernal goiters. I'm definitely glad that in this case we have a CT scan, not just to get the degree of substernal projection, but also the relationship with the trachea and to obtain accurate volumetrics. Because, idea of success after RFA is going to be based on your volume reduction. And if you're basing it on ultrasound measurements of nodules that are bigger than the transducer, that you're not fully seeing the very bottom definitively, you might be dealing with, inaccurate measurements that are going to affect the efficacy of your procedure too. So I don't see anything wrong with, necessarily ablating this nodule as long as expectations are set. Obviously, this patient has like 4 or 5 other nodules that aren't going to be treated. They have a pan-thyroid process going on with a multinodular goiter, and there is going to be a lot of follow-up. And, there's at least a 10% rate of regrowth and lots of future monitoring. And so I definitely agree with Dr. Graves. There's a lot of situations where I can talk someone into surgery because both surgery and RFA have downsides. And I think as long as patients know what the downsides are, they can make their own choice.
Yeah, thanks for those comments. Julia, Dr. Noel, I'm gonna ask you the last question about this, and then Kepal, I don't mean to monopolize the case time. So I think Dr. Graves alluded to the angles being quite difficult. And I think that's something that can be easy to underestimate how accessible a nodule is. When you perform an FNA, you're usually performing it with a 1.5-inch long needle, but when you perform RFA, your electrode is 7 to 10 millimeters long, and the angles can be quite difficult. Do you have any tricks or tips about how to actually access these large isthmus nodules when you do tackle the problem, in terms of just what trajectory to take, or which side to come in, or whether to come a little bit from each side, or what kind of approach would you recommend?
Yeah, I think you can do a couple of things. These cases are challenging no matter what, but you start with positioning the patient, and this is where your pre-procedural ultrasound comes in to make sure that the patient can actually tolerate the neck extension in which you need to have them in to adequately access. There are some probe choices that you could make if they're available to you. I know usually we're using a linear array probe for most of our thyroid ultrasound, but if you have access to the smaller hockey stick probe, the 8 to 18 megahertz, that's something that can work well when you're in the sternal notch and you're losing your contact and wanting to get behind the bone a little bit for better visualization. Hydrodissection I find a little bit hard to do for these cases, and in some situations that it can inadvertently work against you because the hydrodissection can sort of push the nodule more inferiorly into the mediastinum. So I, for the most part, don't perform a lot of anterior hydrodissection. Maybe for this patient, I would do some laterally to try to get the carotid to separate a bit. But in terms of thinking about how to do your order of operations, it's best if you can start low as possible, in part because the nodule will swell as you continue your procedure. And you have best access to the low part early. The patients are going to start to get a little squirmy. They're going to lose a little bit of their neck extension. And you'll find that bottom part that was visible to you for the first 15 minutes, you can't get back.
Those are all of you really insightful comments. Kepal, do you have any other comments or questions or anything from the audience about this
topic? This is great. We've got a couple of questions from the audience, real briefly, because in the interest of time, I don't want to get too much into all the questions. But how many times can you ablate a large nodule, and how long would you wait between ablations? And does body habitus play a role? So I'll let each one of you pick one of those questions.
Yeah, I mean, in theory, you can ablate a large nodule as many times as you and the patient care to. I would say the caveat being that if you're going to attempt another ablation, that you actually have some what looks like visible remnant thyroid tissue to target. Maybe we'll talk about this later, but as the healing process continues, most patients will get kind of this almost like a scar ball effect in part of their nodule. And it's firm, it's fibrotic, it doesn't have much vascularity, and retreating that is not necessarily going to result in a lot of additional volume reduction. And there are now a couple of papers that show that, not surprisingly, each subsequent RFA session results in a more modest volume reduction than the initial.
Great. And anybody else for retreating, just timing of retreatment? Would you wait a full year? Would you just, if you're seeing regrowth early, what are your thoughts on that?
Yeah,
Hopefully you can hear me now.
Yes, we can.
You're back.
I do push people to wait at least 6 months to a year. Sorry, I'm going to turn that down. To really try to see what the benefit is going to be. So if I can get them out to a year, I think the longer you can wait, the better. Not only are you going to see what your final or close to final effect is going to be, but also, as Julia was saying, you'll have potentially a better delineation of where there may be viable tissue and where there's good treated tissue on that ultrasound.
Right.
Was there a question about BMI?
Yeah, this is in general. Is there a cutoff, or how do you assess for that, and how does that play a role in your decision making?
Vicky's shaking her head.
Yeah, I mean, I think it's really like the ultrasound, right? So the BMI doesn't really matter as long as you're going to have an accessible nodule.
Right. Great. Excellent.
Great.
All right. Should we move on to our next case?
Yeah, so here's the post-ablation. It actually turned out to be fairly accessible, but this is, I don't have the final volume reduction on this patient yet. This was a recent case. So I appreciate all your comments. And here's another case that Kepal's gonna pose to you.
All right. So we'll move on. So this is a 49-year-old male with a left thyroid nodule for about 5 years. TSH was around 0.42. He had an ultrasound done, TR4, we'll see it in a couple of seconds, 6.2 centimeter. FNA was B3. ThyroSeq did show a TSH receptor mutation with a low malignancy risk of less than 3%. He did complain of some anxiety and palpitations. Can we move to the next slide? I think, Lisa, you have the yellow. And he did have an uptake scan which showed this was a hot nodule. And then the next slide. And this is what it looked like. So it was about 6 centimeters in size, left-sided, hot nodule. He does not want to have surgery for this. Can we do the next slide? I guess press, yeah. So what are our options in this situation? So we'll start with, I don't know, Sean, what do you think?
Well, I think that there's a lot of red flags here. But I think that, overall, it's not impossible to do RFA in this case. But, the fact that it was indeterminate on cytology, the fact that it has a pretty large size, I'm not sure what the volume turned out to be, but it's probably more than a 20 mil nodule. And so hot nodules that are of that size have a lower rate of TSH normalization on one treatment. And so it's pretty hard to completely, fix a hot nodule of that size with one RFA treatment. That being said, if they are up for the longitudinal follow-up and potentially multiple treatments in order to get that normalization, and they're adamantly against or have good reasons why surgery or radioactive iodine might be contraindicated, RFA is still feasible. I guess that's where I would start.
So he does have a history of small B-cell lymphoma, and for that reason, he does not want to have radioactive iodine because he's afraid of the risk of secondary malignancies from radioactive iodine. Although we all know it's pretty rare, but nonetheless, for him, that's a really important factor. So can we press the next? So we talked a little bit about his thermal ablation. So which modality? So let's say, we have several options here, right? So, Julia, what do you think about from thermal ablation? I mean, is this a patient that you would think about radio frequency versus microwave? It's a large nodule. How do you decide?
Yeah. And I think as Sean alluded to, this is generally the patient that I am trying to encourage more in the direction of surgery. But if we are coming to this place of we're talking about ablation options and that's that, I only, in terms of thermal ablation, I only perform RFA. However, microwave ablation does have some benefits when it comes to larger nodules. It produces higher heat. It's faster to achieve the temperature required to cause coagulative necrosis. And so the treatment overall can be a little bit faster. I think with the caveat that because you have a greater degree of thermal energy and thermal spread, that you really have to be careful of where your kind of where your peripheral limitation of ablation is. But you know, that could be a potential application for microwave.
Is there any other thoughts? So we did repeat the FNA just to let you know. And the second FNA did come back benign. And I guess this next question really about counseling the patient, we kind of touched upon it a little bit. I mean, Vicky, what else would you talk to this patient about? Like we talked about, I tried to convince him. I completely agree with the panelists. I did not want to do ablation on this patient. I said he would be much better served with surgery if that was an option. Large toxic nodule, benign, one treatment, he'll be done, take it out. But he was truly adamant about not having surgery, and he was okay with having to come back for multiple ablations if necessary.
Yeah, I think this brings up a good point, and it's like we are seeing all the patients are really pushing us, and it's depending on how you see it. Some days I think it's really tough. Some days I think it's really exciting because we are in this very special place of being able to kind of grow with the patients. And we are all seeing patients that are pushing us, right? They're like, doctor, I do not want surgery. And we ourselves are kind of like climbing a little bit more each day as our experience grows through the years. So, I wouldn't say no to the patient. And I think as long as their expectations are realistic, we're doing this, what's the goal? Why are we here? Why are we doing this? The goal is to have a euthyroid patient. And we need to quote the patient, like what are the percentage, really realistic expectations as best as we can with the data that we have. So I would tell the patient, listen, we can try. And I need to make sure you're safe. So when you do something like this, you have to make sure that you do it in a safe way that's not going to cause any complications. And then see where you are, and definitely counsel that it's unlikely to happen in one ablation session.
Yeah, he's known about this for 5 years, and he's been waiting for this magic treatment where he doesn't need to have surgery anymore, and somebody can, quote unquote, just zap it and make it go away. And it was a tough discussion to explain to him that it doesn't really work that way.
It's not a magic
it's not going to make it go away.
Not a magic wand.
Be there.
I would add that the cases that I have done surgery on after ablation have been toxic nodules, where even when it works initially, they may be able to get off of methimazole or become, alleviated of their symptoms. But unless you ablate even more thoroughly than just a non-functioning nodule, they're very prone to coming back. So, yeah.
I agree. Absolutely.
Yeah.
So I did ablate him.
Congratulations.
We did I got like a 50% reduction, not the best. But did get down by 50%. His TSH really hasn't budged. It's still around 0.5, 0.6. He says he feels better. I don't know what that means, to be very honest with you. But he says he feels better, and he's very appreciative of the fact that he was able to avoid surgery, and we were able to shrink this. And he's open to the fact that I think, Sean, you mentioned before, that if he needs to come back in the future, if this grows again or if it becomes symptomatic, he's happy to have another ablation if necessary.
I think he's maybe maybe this is a good time just to mention that this is where I think all of us feel, and maybe all of you in the audience feel, that surgeons are really in the best position to be able to offer the spectrum of options to the patient and to treat not only the failures of alleviating the symptoms or the toxicity, but to treat complications when they arise. So we're just thrilled that there is so much participation in this webinar. The registration has been phenomenal. We're glad you're here and glad you're interested in learning, or you're interested in improving your skills and knowledge. And this is where, I mean, the menu keeps growing for what we have to discuss with our patients and maybe offer our patients. So it's great that we can speak from experience on all the different options pretty much. We don't
Absolutely.
perform radioiodine ablation, but I think we know a little bit about that too. But
Absolutely. So, I mean, Claire, how long do you follow these patients? Like, so this patient now, you know, so do you tell the patient, well, this is what, you know, this is the situation, go follow up with your primary care doctor and endocrinologist and come see me if necessary? What's your protocol for following these patients? How long are you going to follow them? How are you going to follow them?
Yeah, I do not send them. I keep them. The how long is becoming more and more of an issue as I do this longer and longer. So I haven't totally decided on that yet. But I tend to see these patients back at about a month after the procedure, as long as they're doing well. Obviously, they can come sooner if needed. And we check a TSH at that point. I then see them back 6 months, and this is for, you know, everyone. I keep a little closer eye, depending on what the thyroid, if this is a autonomously functioning nodule, depending on what their initial TSH is at that 1 month after the procedure. I will, depending on the size, but I will typically hold methimazole if it's a fairly small nodule, and I'm pretty confident that we can test it out and they're not terribly symptomatic. I'll hold methimazole, check it about a month after the ablation, and if they've normalized, then I check it about 3 to 6 months later. And then I get an ultrasound at 6 months after the procedure and a year after the procedure, and then I go back to yearly ultrasounds. And I do see a question in the chat about ultrasound. I will typically have our radiologist do it because I don't have the ability to save our images from clinic ultrasounds. I offer them kind of a quick check-in at that 1 month point. I don't send them for an official ultrasound then, but we can kind of take a peek in the office if they want to come in. But I see a lot of patients that are coming from far away. So they'll frequently do a quick video visit and then get an ultrasound locally about a year, or 6 months and then a year after. But I am hanging on to them. I think ones that are further out and we're back into this surveillance mode of yearly ultrasounds, I feel comfortable sending back to their endocrinologist or their primary care doctor. And we're kind of testing the waters with that right now.
Excellent.
Do all of you counsel your patients who do go elsewhere for follow-up ultrasound to inform the sonographer or the referring physician that the ultrasound appearance will change and the TIRAD system is not allowed to be applied to these post-ablation nodules?
Yes, absolutely.
I tell the patient, I think the patient is the best person to know that and say, hey, just so the ultrasonographer wherever is gonna be scared looking at this nodule, and I know why it looks like that. So let them know. But yeah, I think it's so important to tell the patient and have the patient be aware of that, and not just their referring provider.
That's
another question from panelists. How often are patients seeking you out for ablative procedures versus you offering a patient who came to, let's say, for surgery? You say, here's another option. We can actually do ablation. So what's your overall breakdown in that situation? Is it more patients seeking you out, or are you or is it 50-50, or are you offering patients an option that they weren't aware of?
I think it's evolved over time. And, more recently, I think there's just a larger internet and social media presence for these patient advocacy groups and just more readily available information. So, I've had patients tell me, well, my endocrinologist told me that I needed surgery and I didn't want surgery. So I went online and I Googled alternatives to thyroid surgery. And,
Yeah.
they see ablation as their first, 50 results and then find out who can do it for them. So more recently, I'd say almost everyone that comes is specifically looking for this.
Yeah, I bring that up because I just for kicks sake the other day I put in just in ChatGPT, options for treating thyroid nodules, and I got to tell you, ablation's up there. And so
Yeah.
people are going to be seeking this out. At least they're going to be asking about it. Just, hey, what do you think about this? Am I a candidate for this? And I got to tell you, over the last maybe 6 months to last 6 to 8 months, I would say more than 50% of my patients are at least asking about it. Even when it comes to cancers and everything, they're like, well, is this thing ablation an option?
Yeah.
Thankfully, I say no to 90% of them, but still, it's going to be something that it's going to become part of our conversation as we talk to our patients. Where once again, having been doing this for a while now, like most of us here, it went from offering total thyroidectomies to everybody to talking about lobes and totals, and now talking about ablations, lobes. I mean, it's a conversation just getting more and more complicated.
Yes.
Very true. Well, we have 10 minutes
Let's go
left,
one more case.
and
Yeah, let's go.
let's go to the last case here,
Right.
and save the last couple minutes if we are just trying to get any questions in between. So,
Absolutely. So this was a 37-year-old female found by her primary care doctor on routine exam to have a thyroid nodule, no symptoms, no history. You can see over here the ultrasound findings. It was a 4.6 centimeter right thyroid nodule occupying pretty much the entire lobe. It was a TR3 nodule. Go to the next slide. And this is what it looked like. So I don't know if you, Vicky, do you want to kind of just describe this nodule a little bit?
I'm looking at it right now. So it's that inferior based nodule here, right?
Yeah. Well, it occupies the entire lobe pretty much, but it's kind of like a multi kind of,
Yeah,
nodular nodule.
exactly. So multinodular nodule with some cystic, kind of heterogeneous in appearance, with some cystic components, mixed solid and cystic, but mostly solid. Yeah.
Yeah, that's fine. Good. So patient had a biopsy. Next slide. Which came back AUS, and then there should be the next slide right there. And this is what ThyroSeq showed. It's currently negative. So, I'm not even sure what that means, but it's currently negative. It may not be negative tomorrow, but it's currently negative. With a low, approximately 5% risk of malignancy. And it has a DICER1 mutation at an allelic frequency of 19%. All right, so next slide. Patient does not want surgery, so she was sent to me for ablation of this 4 centimeter nodule, which is currently, she was trying to explain to me this is negative. So is she a candidate for ablation? Vicky's shaking her head already.
oh, sorry.
Yeah, I mean, I see. So I do ablation of nodules that are indeterminate because we have protocols to follow these patients, and I think that's important to tell them that we don't have an abundance of data for indeterminate nodules with benign molecular testing. But in my mind, they're similar to Bethesda 2 lesions, where you really want to have this distinct nodule that's causing a symptom that you're going to improve with volume reduction, because the goal there is volume reduction. It's not going to be complete ablation of the nodule. So again, no magic wand, the nodule's not going to disappear. Can you reduce the volume of that nodule, and what is that going to translate in terms of symptomatic improvement for the patient? And just looking at this ultrasound, I'm not quite seeing how this is going to benefit the patient, right? And then that DICER mutation adds a little extra, concern there, for sure, right? So I would not favor ablation. That would not be my first offer here.
So
I would say either observe, either monitor the patient or surgery.
So when you're doing indeterminate nodules, you're saying these are indeterminate nodules with a negative molecular profile. Is that correct?
Yeah, correct.
Okay. Anybody else have any thoughts on indeterminate nodules? Sean?
Yeah, I would say that there's a big difference between a ThyroSeq report that reads negative versus that currently negative. Because for negative, there's no mutations detected, 3% risk of malignancy. It's essentially equivalent in my mind to a benign cytopathology call. Whereas that currently negative, where there's low level Dicer1 mutations, it's thought to be, either up to 10% chance it's malignant right now, and it could be pre-malignant. I also think it's really hard with that nodule, which is really more of a nodule cluster or conglomeration of nodules, to accurately know if you got the correct genetic data from that ThyroSeq biopsy. And I think that looking at that nodule cluster, it would be really hard to assess your level of success, just because like it's not like it's a well-defined nodule, right? It's like the whole lobe is affected. And so I think it'd be really easy to call it wrong. It's going to look uglier. It's going to be really confusing. You're not going to know if it's evolving in the wrong way. And so I would say definitely for me, this would be a no.
Any other thoughts for? Yes, Kyle.
Yeah, I just wondered the nodular nodule sort of is a little reminiscent of Hashimoto's thyroiditis pseudonodularity. So I wondered if you knew if the patient had positive TPO antibodies, and their whole thoughts on it doesn't eliminate the option of ablation, but also that population is more prone to ultimately developing hypothyroidism anyway, which if they're on the fence or if they're already sort of high normal TSH, might convince them that maybe they're better served with surgery. But just
Yeah,
curious if that
great
patient.
point. Great point. Yeah, no, her antibodies were negative,
Uh-huh.
and she had normal TSH.
Uh-huh.
This is kind of a finding by her primary care doctor, but it is definitely a strange looking kind of nodule, pseudo nodule,
Yeah.
a nodular kind of appearance. So I was successfully able to convince her not to have ablation. And so this is a patient that did not have
I
and did
also
actually have
just
surgery.
wanted I also just wanted to point out that with the Dicer mutation, like if you did choose to ablate the nodule, like that's a nodule that's going to have kind of continuous growth, neoplastic behavior anyway, and you're not going to change that underlying behavior with ablation. So if you do it, it's probably going to come back and you're going to be in the same situation.
Yeah, I totally agree. I mean, it was really to highlight that this difference between what we call negative molecular tests versus currently negative, and I think there's a big difference there, and it's something we want to make sure that we don't miss. We have 2 minutes left, and we promise to get everybody out of here in 2 minutes. So I don't know if we want. I mean, I see Dr. Parangi's on the line.
Yeah,
Dr.
I
Singer's on the line. I don't know if you guys want to say 2 words and kind of just
I
give
will
us your
say
thoughts.
just more than more than 2 words. I just want to thank all of you for joining us today. I think that this is the beginning of a fantastic collaboration. I thank Lisa and Kepal for getting this wonderful group together and for you giving your time so graciously. And I want to thank Mike and Bevan, you, the head of AHNS, for really helping open the door to working cooperatively together and really helping the surgeons who are helping the patients. So thank you very much.
Thank you, Saray.
Thank you.
Well, thank you to all the panelists and to the audience and to the leadership. And we're delighted that this was a chance to share thoughts and insights. And we look forward to the next webinar that's going to be co-organized by
Yes.
these valuable organizations. So thanks, everybody, and have a good night.
Thank you all.
Bye. Bye,
Thank
everybody.
you.
Good night.
Thank you.
Bye.
Hi, thank you.
Great job, guys. Thank you.
No shake, Vicky?
They are not answering. I think that they're protecting me against this because they know I was doing this webinar, and I'm like, please tell me what's
They're
happening.
gonna be doing it in the middle of the night.
So I have to call them. I'm like, no, I want you to actually set it up. I want to pitch in the OR right now.
Yeah,
So I'll call the fellow. I think she decided not to, not to
good luck.
talk to me about it. Anyways, it's nice to see
Good
you,
to
Claire.
see you.
All right, bye-bye.
Bye.